Hello and welcome to the NCLEX Made Simple YouTube channel. Here we prepare content that can help you with your NCLEX exam. And today we are going to tackle a very important condition called Myasthenia gravis. Myasthenia gravis comes under autoimmune disorders. So it's an immunological problem. Myasthenia gravis comes from Greek and Latin words that means grave muscular weakness. So just that you know what myasthenia gravis is all about. Grave muscular weakness. So the muscles become weak. Which muscles? You are going to learn as we continue. It is an autoimmune neuromuscular disorder that is characterized by weakness of the voluntary or skeletal or striated muscle groups. It's an autoimmune neuromuscular disorder characterized by weakness of the voluntary, skeletal, or striated muscle groups. So myasthenia gravis, we have said, it's an autoimmune disorder affecting the neuromuscular junction. So this is where the neurons meet with the muscle. At the junction, the neuromuscular junction, that is where the problem is. It is characterized by varying degrees of weakness of the voluntary muscles. Women are 3 times more affected by this disease than men. It's good to understand acetylcholine. This is a neurotransmitter that plays a role in memory, learning, attention, arousal, and involuntary muscle movement. So acetylcholine is important for muscle contraction. We have several conditions that have low acetylcholine levels. One is Alzheimer's disease, and that is where we have problems with memory. And the other one is what we are discussing today, myasthenia gravis. What happens in myasthenia gravis? Antibodies, mostly produced from the thymus gland, attack the acetylcholine receptors and block them. Antibodies are the ones that go to the receptors of acetylcholine at the neuromuscular junction and block them. And this now is a problem because at the neuromuscular junction, that's where it acts as the bridge between the nervous system and the muscular system. The nervous system, we have the neurons, and then the muscular system, we have the muscle. Where they meet is the neuromuscular junction. It's the bridge. Now acetylcholine is the one that helps with the involuntary muscle movement and contraction of the muscle. So here, the process of muscle contraction is inhibited or halted in by the neurons. Any changes in the neuromuscular junction can result in impaired contractions of skeletal muscles. What are we saying? Any changes that happens at the neuromuscular junction, whether it is the acetylcholine receptors that are being damaged or destroyed by the antibodies, it will result in impaired muscular skeletal muscle contraction. Let us look at the etiology of this myasthenia gravis condition. The receptors at the muscle surface are destroyed or deformed by antibodies that prevent a normal muscular reaction from occurring. I have told you that it is an autoimmune disorder. So the antibodies attack the acetylcholine receptors at the neuromuscular junction. The causative factor for this disease is unknown, but the disorder may have a genetic link. This means that if there is another autoimmune disorder in the family, there could be a high prevalence for getting this disease within the family for the future generations. It is the antibodies that destroy the acetylcholine receptors. We have already said that. We know the thymus gland. From the picture there, you're able to see where the thymus gland is located in the chest. 15% of these patients, they have thymus tumors. So we will see there right alone in the management that even surgery to the thymus gland can be important in helping this disease. There is no cure for this disease, we can only try to manage the symptoms and prevent further suffering. Pathophysiology of Myasthenia gravis. Normally, what we know is that a chemical impulse precipitates the release of acetylcholine from the vesicles of the nerve terminus at the neuromuscular junction. So acetylcholine, it is a neurotransmitter, as we said earlier. It attaches to the receptor sites on the motor end plate of the muscle side, and this stimulates muscle contraction. So what you are saying is, in a normal situation, this neurotransmitter called acetylcholine at the nerve endings that is released from the end of the nerves in the neuromuscular junction tries to attach to the acetylcholine receptors found on the motor end plate on the muscle side, and this stimulates muscle contraction. Now, in Myasthenia gravis, autoantibodies are directed at the acetylcholine receptor sites impairs the transmission of impulse at the neuromuscular junction. Remember, I told you the acetylcholine receptors, they are ready to accept acetylcholine, which is a neurotransmitter, which is now going to help us with the contraction of the muscles. Now, these receptors are blocked, they are destroyed or damaged, and therefore we have few receptors that are available for stimulation. So that is what happens with the Myasthenia gravis. So when there is a understimulation of this muscle, you have reduced muscle movement, and there will be muscle weakness. So let's continue and look at clinical manifestations. Now that we understand what happens with Myasthenia gravis, let us look at the clinical manifestations. There will be increasing muscle weakness. It will continue to increase time after time after time. So something has to be done, because this muscle weakness does not stop increasing. The affected muscles are muscles used for the movement of the eyes. So you might find that the eyelid will drop in the eyes, and it will look like this. It will block the upper eyelid will come over the eye, and that is what we call the falling of the upper eyelid is what we call ptosis. Ptosis, ptosis. The muscles that will be affected also will be the muscles used for chewing. So this patient will have difficulty with eating and also even swallowing, speaking, and breathing. When the muscles for breathing are affected, this is life-threatening, and the patient may need mechanical ventilation. So in severe cases, respiratory muscle weakness occurs. Also, laryngeal movement produces dysphonia. There will be problems with the way the client is talking. Sometimes they produce sound through the nose, and you feel that there will be a dysphonia. Then there will be diplopia. Diplopia is double vision. This client will see double images of the same object. That is what we call diplopia. Those are clinical manifestations of the Myasthenia gravis. So we have fluctuating weakness increased by exertion, and the weakness increases during the day. That is when the patient is most active during the day, and it improves with the rest. These clients, you need to advise them to try and conserve as much energy as possible so that their symptoms may not worsen. Then the extraocular muscle weakness, what we said earlier, ptosis, where the upper eyelid falls over the eye, is present initially in 50% of the patients, and during the course of the disease, it is present in 90% of the patients. So this is a very, very important thing to note about patients with Myasthenia gravis. Head extension and flexion weakness. Weakness may be worse in the proximal muscles of the neck, and this is also a manifestation of myasthenia gravis. It affects those muscles of the neck. The muscle strength, those muscles that will be affected will be the facial muscles, bulbar muscle weakness, limb muscle weakness, especially the upper limbs, respiratory weakness, and ocular muscle weakness. So look at the picture there. You can see that boy, the eye where it shows the ptosis, and also you can see the mouth where it's drooping on one side. There's snarling, and that one shows that the boy is suffering from myasthenia gravis. Facial muscle weakness is almost always present. That's why you look at the face and see all those signs. There will be ptosis, bilateral facial muscle weakness, and sclera below the limbus may be exposed due to weak lower limbs. The bulbar muscle weakness, the palatal muscles, will be present. The nasal voice, nasal regurgitation. Chewing may become difficult because these muscles that involved in chewing, they are weak and makes difficult. So this is a patient who needs a lot of help with taking food. Then there will be severe jaw weakness and may cause jaw to hang open like this. So swallowing may be difficult and aspiration may occur with fluids. So it is very, very important to note that, especially when dealing with these patients, they need to be assisted with the feeding. So coughing and choking can occur while drinking, and this may lead to aspiration. Neck muscles, we say they are involved. The flexor muscles are affected more than the extensors. So limb muscle weakness, we said the upper limbs are more affected more than the lower limbs. The respiratory muscle weakness, that one is also important to note because these patients have weakness of intercostal muscles, and the diaphragm may result in carbon dioxide retention, and this can lead to respiratory acidosis due to hypoventilation. Weakness of pharyngeal muscles may collapse the upper airway. So it is very important to know that these patients with myasthenia gravis may require a lot of assistance, sometimes even mechanical ventilation when a disease progresses severely. So you need to monitor negative inspiration, force, and vital capacity and tidal volume for this patient. There, you need to note that the arterial blood oxygenation may be normal even when carbon dioxide is being retained for these patients. So when you're managing them, monitor negative inspiration force, vital capacity, and the tidal volume. The ocular muscle weakness is asymmetrical, usually affects more than one extraocular muscle, and it is not limited to muscles innervated by one cranial nerve. So ptosis is what we said, caused by eyelid weakness, and diplopia is very common. We say diplopia is double vision, whereby the patient will see double images of the same object. Diagnosis. How do you diagnose this disease? One is through history and physical examination. The other one is blood analysis, elevated levels of acetylcholine receptor antibodies. We have anti-muscle specific kinase antibody. Then the other one is the tensilon test or endraphonium test. Although not very common in US, it is important to know that it can be used to diagnose myasthenia gravis. How do you do the tensilon test? Tensilon, also called endraphonium anticholinesterase, and results in a transient increase in acetylcholine in the neuromuscular junction and theoretically improves strength. So what you do when the patient is suffering from myasthenia gravis, you give it by vein, IV, 2 milligrams at a time to a total of 10 milligrams. So 30 seconds after injection, the patient is observed for improvement in muscle strength. So the client may be given a medicine called atropine before receiving tensilon to reduce chances of side effects like allergy. The heart rate is also closely monitored to make sure that the medicine does not slow the heart rate. So if the muscle strength increases in response to this drug called tensilon, then it is likely that the disease is Myasthenia gravis. IV atropine, it is an antidote. You should get it ready and give if an allergic reaction occurs. There's another test, single fiber electromyography, EMG. It is considered the most sensitive for Myasthenia gravis. Single fiber electromyography, EMG, this is a test that is considered most sensitive for Myasthenia gravis. It detects impaired nerve to muscle transmission. You can also do imaging, CT scans or MRI. It shows the thymus gland enlargement. I told you thymus gland is located somewhere here in the chest, and it is responsible for production of these autoantibodies that go and damage the acetylcholine receptor and the neuromuscular junction. So it shows that these thymus gland are enlarged. And I told you earlier, even during the management, thymus gland thymectomy, removal of this thymus gland, may help in management of this disease. Let us now look at the pharmacological management. You can give immunosuppressive therapy. Here we have azathioprine, an immunosuppressive therapy, and also give prednisolone. Acetylcholinesterase inhibitors are drugs such as neostigmine and peridostigmine. They are mostly used. They help to increase the accumulation of acetylcholine and prevent acetylcholine destruction, helping muscles to contract more effectively. However, side effects such as involuntary muscle twitching, that is fasciculation, and excessive salivation may be present in some patients. So it is good to note that acetylcholinesterase inhibitors such as drugs like neostigmine and peridostigmine, they help with the management of this condition. The first line therapy, you can give neostigmine, bromide, and peridostigmine, and also you can give endrophonium, which is a tensilon. You can also do plasmapheresis. Plasmapheresis, it is done in more severe cases to clear antibodies from the blood. It is administered in myasthenic crisis and in patients who require long-term treatment. You can also do immunoglobulin therapy. So what is important to note here is the drugs that can be used to manage this condition. We have prednisolone and azathioprine. Those are immunosuppressive therapy. And you need to manage these patients with myasthenia gravis like any other patient who is now immunocompromised. So this is a patient that you should teach to avoid large crowds, or patients even with respiratory infections, because now they have low immunity because of the drugs that you are giving, prednisolone, azathioprine. Then you give acetylcholinesterase inhibitors. These ones help with increased muscle contraction. They help at the neuromuscular junction. The other thing is surgical management. I told you earlier, thymectomy, which is the removal of thymus gland, is performed to reduce production of antibodies that result in damage of the acetylcholine receptors at the neuromuscular junction. You can see from the diagram there where the thymus gland is, it is removed, and it helps in managing this condition. So corticosteroids are used to suppress the immune system to decrease production of auto antibodies. So manage this patient like any other immunocompromised patient. Plasmapheresis, we have said, this is a process by which plasma is separated from the formed elements of blood. Plasma is discarded, red blood cell electrolyte are returned to the client. So that's plasmapheresis. Something very, very important is the complications of myasthenia gravis. This one is tested a lot in the NCLEX exam. So you need to be able to differentiate between a myasthenic crisis and a cholinergic crisis. So let us look at the two crises. In myasthenic crisis, it occurs when there is under medication. In myasthenic crisis, it occurs when there is under medication. It can also be as a result of an infection, surgery, and emotional distress. On the other side, cholinergic crisis, it occurs as a result of over medication. So when you give these drugs, anticholinesterase drugs, when you give them in overdose, it can lead to cholinergic crisis. So what you need to do, if the patient is taking these drugs, you need to withhold anticholinesterase drugs and administer an antidote. So we are going to learn about that. So in myasthenic crisis, there will be increased heart rate, the blood pressure will also be increased, respiratory rate will also be increased, there will be bladder and bowel incontinence in myasthenic crisis. Also, there will be decreased urine output in myasthenic crisis. There will be absent cough and swallow reflex, which now may necessitate to us to do the mechanical ventilation for the client. So there will be temporary improvement of symptoms with administration of tensilon. So in Myasthenia gravis, we said during the pharmacological management that we give anticholinesterase drugs, and we gave examples of neostigmine, peridostigmine, and endrophonium, which is also known as tensilon. So when you give tensilon and the symptoms improve, that is a myasthenic crisis, because as we said earlier, this condition is caused by under medication. It is found when your patient is given drugs and not taking them. There is a problem with the drug compliance, and the patient is not taking as prescribed. Sometimes skipping the doses, and the patient may end up in myasthenic crisis. So the symptoms improve with administration of tensilon. Now, in cholinergic crisis, there will be decreased blood pressure, and this decreased blood pressure is because of the vasodilation. There will be abdominal cramps, nausea and vomiting, and diarrhea. The other thing is blurred vision. There will be blurred vision. Also, pallor, facial muscle twitching will be found in cholinergic crisis. Constriction of pupils. So it is very important to note that the pupils will be constricted, not dilated, not meiosis, but constriction of pupils. Then when you give the drug tensilon, it has no effect in cholinergic crisis. Remember, this is over medication. One of the medication to use while managing this condition is tensilon. So, and as we said earlier, cholinergic crisis is caused by over medication. So when you give tensilon, you are still over medicating this patient in cholinergic crisis. So it has no effect. There will be no improvement of symptoms when you give this tensilon, as opposed to in myasthenic crisis, where we found that the symptoms improve when you give tensilon. So the symptoms improve in cholinergic crisis. Symptoms improve when you give the antidote, which is atropine sulfate. So when you administer anticholinergic like atropine sulfate, the symptoms improve. So you need to withhold all anticholinesterase drugs, neostigmine, peridostigmine, endorphinium, tensilon. Withhold them and administer the antidote atropine sulfate. So for now, you can be able to differentiate between the cholinergic crisis and myasthenic crisis. Under medication, over medication, blurred vision, increased blood pressure in myasthenic crisis, decreased blood pressure in cholinergic crisis due to vasodilation. There will be constriction of pupils in cholinergic crisis. Tensilon has effect on improvement of symptoms in myasthenic crisis, but in cholinergic crisis, it has no effect at all. Actually, symptoms improve in cholinergic crisis when you give the antidote atropine sulfate, which is anticholinergic drug. So let us look at the nursing interventions. For the patient who is suffering from Myasthenia gravis, always maintain a patent airway, ABCs. So the first thing is maintain a patent airway. Assess the swallowing to prevent aspiration. Keep appropriate equipment available at the bedside, that is oxygen, suction, ambubag, endotracheal tube. Just keep them ready. Promote energy conservation measures. We said that this is a condition that becomes worse with exertion. So you need to promote energy conservation measures. Also consult a physical therapist. This is a patient who has weakness of the muscles, and muscles need a lot of attention with the physical therapist. Consult occupational therapist for assistive devices to facilitate activities of daily living. Also consult with speech and language therapist if weakening facial muscles impact communication. So this is where now you bring in a speech or language therapist to help when the facial muscle weakness is severe and it's impacting communication. Also monitor intake and output, serum albumin levels, and also daily weight. Know the signs and symptoms of both Myasthenic crisis and cholinergic crisis so that you can be able to manage this patient effectively. Administer medications as per their order. Those are the nursing interventions that need to be undertaken. Let us now look at the patient teaching. You need to teach the patient and family disease process, complications, and treatments. Teach patient about their medication uses, the dosage, and also you need to teach the patient how to avoid crowds and individuals with respiratory infections, as they can be immunocompromised due to their disease and the immunosuppressive medications. Remember, we use prednisolone and azathioprine. Those are immunosuppressive agents, and they can make the patient immunocompromised. Teach the patient the drugs to avoid in Myasthenia gravis. For the antibiotics, the patient should avoid aminoglycosides such as streptomycin, quinolones such as ciprofloxacin, macrolides such as erythromycin. Patients should also avoid beta blocker agents. Examples are propranolol. Patient should avoid local anesthetic agents with procaine, should avoid magnesium, quinines, also should avoid non-depolarizing muscle relaxants such as tuberculine and galamine. Lastly, the patient should avoid botulinum toxin type A vaccine. So the nursing diagnosis that you can find in Myasthenia gravis: number one, ineffective breathing pattern related to intercostal muscle weakness. That is number one. Number two is ineffective airway clearance related to muscle weakness. Another nursing diagnosis is impaired verbal communication. Remember, the facial muscles are involved and they are weak now, and sometimes they can affect communication. So impaired verbal communication related to weakening of the larynx. The other one is disturbed sensory perception related to ptosis. Ptosis, we said, is whereby the upper eyelid falls and over the eye, and now there will be disturbed sensory perception related to ptosis and diplopia. Those are the nursing diagnosis for this condition called Myasthenia gravis. So we have come to the end of our topic, Myasthenia gravis. We have learned that it is an autoimmune disorder, and the patients are usually immunocompromised because even the treatment that is used to manage this disease, we use immunosuppressive agents such as prednisolone and azathioprine. It is important to remind the patient to take care of themselves and avoid crowded places. Also avoid other people with respiratory infections. You need to provide nursing intervention properly, and also patient teaching. You need to allow them know which kind of drugs that they should avoid. The other thing, and that this is usually tested in NCLEX in the case study, it, it's the differentiation. You need to know how to differentiate between myasthenic crisis and know how to manage a myasthenic crisis and also a cholinergic crisis. So it is good that you take a good grasp of this important subject, and this will help you to pass the NCLEX whenever those kind of questions are presented to you concerning Myasthenia gravis. So as you know, when we reach the end of the teaching, there is always a chance for you to test your knowledge. We have provided for you 10 NCLEX style questions that will help you revise the topic Myasthenia gravis. These questions have the answers and also the rationale, so you should attempt them and see how much you have been able to learn concerning Myasthenia gravis. Again, thank you for being with us all this time. If you have not subscribed to our YouTube channel, kindly subscribe to the channel. This will help you to get notification of our videos immediately they are uploaded on our YouTube channel. So take your time and look at these questions, and let's see each other in our next video.